Hi, my name is Terry Kuti. I am the founder and director of Deep Sea Foundation. I'd like to welcome you to the educational channel where we talk about topics related to breast reconstruction and breast cancer. I'm very pleased today to be joined by a returning guest that I'm so happy to see this morning, Dr. James Craigie, who practices in the beautiful city of Mount Pleasant, South Carolina, just outside of Charleston, at the Center for Natural Breast Reconstruction. And he works with his surgical colleague, Dr. Richard Klein. They focus primarily on autologous breast reconstruction, a number of different flap options that take the patient's own tissue, blood vessels, and they reconstruct breast with it. So this morning, Dr. Craigie and I are going to address some questions that both of us frequently get in our breast cancer and breast reconstruction community about tools. I'm going to call them tools, Dr. Craigie, for lack of better definition. The things that they use in surgery that sometimes patients have questions about before surgery, but also after surgery. So, Dr. Craigie, first of all, I want to welcome you back. It's so good to see you.
Thank you, Terry. Thank you for having me. It's always a pleasure. And I'm so glad to be back and get to talk with you again.
I know. We love to educate our patients, and I really appreciate your time today because I know that you've already been to hospital this morning, and so really appreciate your time. Okay, so topic at hand today, I will just outline quickly. We're going to talk about clips, why they're used, mesh, and sutures, and I will let you take the floor.
Thank you, Terry. This is a very interesting topic, and I do get that question a lot. People who are going to go through surgery, they want to know, what is going to change with their body. Will there be foreign objects in place? What will you do while you're there? And so I think it's important to know. You mentioned sutures, clips, and mesh. Why don't we start with the last one, mesh, because that's kind of a hot topic. And when people say mesh, that can mean a lot of different things. And there's a big difference between what we call permanent mesh and other things that are mesh-like that are not permanent. And we don't use permanent mesh. Usually that is only necessary if something is permanently removed from and I'm speaking in reference to primarily doing DIEPs where we're using the tummy fat. Permanent mesh would not be necessary or used in those circumstances. However, in times when maybe someone may have had a tram and their muscle is removed, without the muscle being there, then there needs to be something to support the tummy wall. And so there are times, not always, that permanent mesh might be needed under those circumstances. And so the downside of that is permanent mesh is not necessarily, it's permanent, but it's not living tissue. So if it's needed in its place, all sorts of potential problems could occur after a DIEP, or I'm sorry, after using it for repair of the abdominal wall if the muscles were taken out, because if the mesh wears out or pulls through, then there's no muscle there to hold the tummy flat. And so when you hear about mesh, permanent mesh, realize it's very unusual to have that, to use that after a DIEP. The whole purpose is not to need that. We would never put it in. Again, it has to be, it's permanent, it stays there, but it can get infected because of the foreign body. And so we really always want to avoid that. We don't want to leave things or use tools during the surgery that later can be a liability or a problem. And using permanent mesh, it should not be necessary after a DIEP.
And Dr. Craigie, I would think a lot of this, listening to you right now, has to do with the skill set of the surgeon. Does it not?
Oh,
Well, in terms of, I guess specifically in terms of performing a DIEP and not using mesh. That's what I'm referring to.
correct. Yeah, the only reason that it would be necessary to use a permanent mesh if during a DIEP the muscle had to be removed, which
Correct.
the two things can't really occur together.
Right.
It's not a DIEP if the muscle is removed. Also, the lining that surrounds the muscle that is very important as well, it doesn't need to be removed. So if someone has a muscle flap procedure, that tissue often is removed. So when things are removed, then the abdominal wall has all these layers that are very important, and so the permanent mesh is used as a replacement for those things. But unfortunately, it's not living tissue; it doesn't move, and it can lead to problems. So it really would be used only when there were absolutely no other ways to repair that part of the abdominal wall. So it's very, very unlikely to be needed in a standard DIEP.
Yeah.
Now, there are other mesh-like things that can be used and can be very helpful. And this can be confusing because it's not the same as permanent mesh. We happen to use what we call a patch. We don't call it a mesh because we don't want to create confusion and concern, but there is an absorbable material, it's called Phasix, that we use after we do a DIEP, not because we've taken the lining around the muscle away or not because the muscle has been removed, but to hold the muscle flat after we've done a repair so that when the repair heals, it's stronger. And also that while the muscle is recovering from having surgery around it, it keeps the muscle from being stretched out. So we call it a patch because we don't want people to think it's permanent mesh, and the body breaks it down over the course of months and it goes away. And so there's no associated liability or problems that can occur later. In fact, it goes away eventually, but what it leaves behind is some sturdy tissue that helps hold the tummy flatter, and then also helps the repair that we've done in the donor site to become more like an abdominoplasty. So that's a type of mesh-like material that can be used and is very helpful, but it's not permanent and it goes away, and it's not permanent mesh. And the difference is if it's permanent, it can get infected years down the road. If it's permanent mesh, it's not being broken down by the body, bacteria can adhere to it, and because it doesn't have a blood supply, antibiotics cannot get to it. And so an infection with permanent mesh means the permanent mesh would need to come out. And so then what happens to the tummy wall? So again, we want to avoid that. It should not be necessary. But other things, absorbable material is frequently used, and if it goes away, then it has a function, but there's no residual left behind in a patient that's had that done. We also use it because we feel like it helps relieve some of the discomfort after surgery. We actually call it a comfort patch. That's just our way to refer to it in the operating room because we want everyone to understand what we're doing. There are other things that we use in surgery that we place that remain, but in general they tend to be also absorbable, meaning that the body breaks them down. They serve a function for a period of time, and what I'm speaking mainly of is suture material, things that we close incisions with, we approximate the layers, things that we repair the lining around the muscle. Those are all what we call sutures that we're hand sewing things back together as part of the surgery. And typically on a DIEP, we might use 70 to 80 suture needles that we keep track of. And we use those things for lots of different things. That absorbable suture material goes away. So it's not something that stays there permanently, just like the Phasix patch that we use that's broken down by the body. It stays there for a while and holds things together until the body heals, and then the strength of the repair takes over. There are times when permanent suture, they're very similar, might be used. And we use permanent suture when we're sewing the tiny arteries together. So do an anastomosis between the flap artery and the internal mammary artery. It may be a 2 millimeter vein, no, I'm sorry, a 2 millimeter artery. And we actually sew that together with tiny nylon sutures that are finer than a strand of hair. So they'll stay in there forever, but they're so tiny that it's unlikely, there's really no risk that that ever induces a reaction or causes a problem, because it's a very small amount. Otherwise, all the sutures that we use are all absorbable and they're temporary. There are a few other tools that are necessary for the surgery that are not absorbable and or permanent, and can show up later at during X-rays and such, that people may be surprised, what are those things in me? And those are surgical clips. They come in various sizes, and in order to do a DIEP or any other type of microsurgical breast reconstruction, where we're teasing out the blood supply to the tissue that we're taking in order to make a breast. We want to have blood, an artery and vein that nourishes that tissue, but we don't want to take away the blood supply to the other parts of the body that the blood vessels travel through.
Right.
And so that requires dividing and separating our blood vessels that we want from side branches. And frequently that's done with little tiny titanium clips of various sizes. And they can be from the 2 millimeter long clip to maybe 3 millimeter long clips, and they are titanium. And so they're safe for people if they need an MRI or, of course, a CT scan. But if you have an X-ray or a CT scan in that area, you will see literally lots of little tiny clips. And they're so tiny that they're very unlikely to cause any problems. Sometimes when they're in the body will react and basically create a little lining around them, and it just sits there. It's possible, though, if they're very close to the skin, some of the bigger ones, you might be able to feel them. And every now and then the body can work one out.
Yeah.
But it's extremely unlikely that they're going to lead to any problem or to set off the metal detector at the airport or anything of that nature.
And these surgical clips, from what I've read, so you can clarify this for me, there's a term called ligate, and the surgical clips really are used to help with any bleeding out, just from a layman's term. So explain that to us. That's the way I think of surgical clips. They're really a safety issue for the patient.
Absolutely. So the little tiny, the blood vessels are very small, and they're connected to each other through side branches. And so as you go along, little tiny side branches of veins and arteries need to be separated from the vessel that you want to keep. So that requires one clip on one side and one clip on the other, and then we cut in the middle.
Yeah.
And that allows us to divide those side branches so that they don't bleed, and so that we don't have to strip the blood supply to the surrounding tissues that we leave in place. But for example, on a typical DIEP, we may use up to 150 to 170 of those tiny little clips, depending on how complicated the process of teasing out the blood vessels are. So there are quite a few of those high. But again, the small ones are about 1.5 millimeters long. The larger ones maybe up to 3 millimeters. So they're very small, but are something that you can see on X-ray. Rarely, if they're right under the skin, it may be possible to see them, but they're very important. We could not do the surgery without them. It's possible that you could tie little knots around all of those side branches, but that's very tedious. Not only will it take much longer, it's much more risky that you would damage the blood vessels you want to keep. Trying to do that if you had to do it 150 times.
Yeah, no kidding. One thing that comes to mind for me too, when you're talking about these three tools, I call them the clips, the mesh, and the sutures. One thing that I want patients to know that I have learned, through my years of advocacy, none of these tools could ever be used without a lot of testing, a lot of studies, and all of that to maintain patient safety. Do you want to address that for just a moment? I don't think patients often realize the work that goes behind developing these products and the safety and efficacy of them for patients.
Sure. I mean, these surgical clips have been around a long time. I can't tell you the exact history and how long, but they're used by all specialties. And the clips are made of titanium. And so all of that has to be passed through the FDA so that these things are shown to not break down, to not release chemicals in the body.
Right.
They're basically inert. And when they've served their function, they stay there. But then there's no chance for them to go and move around and cause problems because they're held in place by the tissue that they're clipped to.
Yeah. Yeah.
But yes, they are very, been studied extensively. They have to be approved by the FDA, and these have been around for literally decades. The surgery that we do, this type of surgery would really not be feasible without some type of surgical clip. Not to mention the risk for bleeding that can occur after surgery if these little tiny blood vessels are not taken care of and treated in a way that they're not going to open up and bleed.
Yeah. Well, I have to tell you, Dr. Craigie, every member of my family, my husband and our two boys, we have all had various surgeries throughout our life. And so we are walking around with some of these tools that you discussed today, and we're all doing just fine. So, but it's important for patients to know. They ask these questions, they're curious about them. So I really appreciate you taking your time today. Is there anything else you'd like to add or anything I forgot to ask?
There's one other tool that we routinely use, and when we actually sew the arteries together, do the arterial anastomosis. We also do a venous anastomosis.
Yes.
And arteries and veins are similar. They're very small, but the walls of each are different. And so in our practice, we use what's called a coupling device to connect the veins. And there's literally and they range from size. It's a device that goes into the end of the vein and allows us to join the veins end to end like this. It's useful for veins because the veins are the walls are so thin and so delicate, and they're more difficult to sew with suture. And this coupling device makes things more efficient and easier, and fewer problems with the vein shutting down. But there are tiny little metal titanium spikes and a very tiny cuff of silicone. And it's as large as 3 millimeters in diameter, and stays on the outside of the blood vessel, holding the ends together. And that as well is never leads to any problems, and is a very beneficial tool that makes a huge difference in being able to do this type of surgery.
Yes, I'm glad you mentioned that. So if these are veins, let's say we have one that's kind of tiny, and they're the veins you're going to tie together. Arteries are the veins. One's big, one's little. You put those couplers in kind of as a rigid, piece to keep them open so that when you put them together, different sizes, you put those couplers in, then you've got this rather than maybe this or this. So if I'm demonstrating this in the right way, in a very simple way, it kind of holds them together like this, and then you start doing the anastomosis around there. Is that correct?
This little device, actually, you pass the vein through. It's like a donut with spikes on it, and there's two of them. And one vein goes through one, and one through the other, and then the edges of the vein are put on these spikes that hold the vein open, and then you twist a little turn key, and it brings the two ends together. And there's a little cuff of silicone that's like a donut. The spikes go into it and through the vessel, and so it just approximates the inside of the vessel and keeps it from closing down. Arteries, because they have arterial flow through them, more pressure, and the walls are thicker, don't collapse down the same way. And putting them together is a little bit different. But this device is very helpful for veins which can be tricky to join to each other, especially when they're of different sizes.
Yeah, thanks for that clarification. Okay, I learned so much today, as I always do from interviewing these great surgeons, and I appreciate your time again. What I would like to mention to our viewers on the educational channel, and also, Dr. Craigie will have this on his website also likely. If you have questions about this video or anything else, please drop them in the comment section. I check those frequently, and if I can't answer them, I'll reach out to Dr. Craigie and we'll get them answered for you.
Absolutely. We would love to have your questions.
Yeah. So thank you so much for your time today. Again, I'm talking to Dr. James Craigie at the Center for Natural Breast Reconstruction in beautiful Charleston, South Carolina. Thanks for joining us today.
Thank you so much, Terry. As always, it's great to see you.
Great to see you too.
Come back and do it again.
All right, let's do that. Thank you so much.